Hello, everybody. I would like to bring to you another interesting case. This time, I promise you, this is something rare, which we see once in a while. We see here. This was a patient with massive, obscure, overt GI bleeding. Let me go to the case. This was a 26-year-old tailor from the Northeast who was working in the neighborhood. He presented with bleeding PR approximately 50 ml per day since 5 days and 100 ml one day. So he had quite a massive bleed. He had similar past history on and off since 1 year, for which he had received multiple transfusions. And endoscopy was also done in Assam, and he was told to be normal. When he presented to us, he was in shock. And you won't believe it, the hemoglobin was only 0.6. So we stabilized him, gave him IV fluids, pack cells, somatostatin, pantoprazole infusion. We couldn't do anything until we could stabilize him and bring the hemoglobin at least to 6. So the first thing we did was an endoscopy and colonoscopy. So always we should repeat an endoscopy and colonoscopy in any case, even if it is normal. If there is a massive bleeding, it is important to repeat it to make sure it's not coming from there. See, this endoscopy was done and it was absolutely normal. We went in as deep as possible and it was normal. We can reach up to the duodenojejunal and proximal jejunum with endoscope. So it was normal. Colonoscopy showed altered blood entirely. Even in the terminal ileum, there was altered blood. So that meant that the blood was coming from somewhere in the small bowel. CT enterography showed a thickening and short segment thickening in the distal jejunum and proximal ileum. So now, how are we going to reach this? Let us look at gastrointestinal bleeding. How do we approach this? When we see an upper GI bleeding, what is an upper GI bleeding? Any bleeding above the ligament of Treats, that is at the duodenojejunal flexure, is upper GI. And lower GI bleeding is below that ligament of Treats. And again, we have to know, is it occult or overt GI bleeding? Occult bleeding is the stools will be normal, but the stool occult blood test will be positive. They will usually present with iron deficiency anemias. Recurrently, they'll be getting iron, but they will continue to lose hemoglobin with normal stools. So this way, we have to test stool occult blood and determine it. Overt GI bleeding, the stools will have blood. This is how it will present, the patient's present. Now, if we see upper GI bleeding, what are all the causes? Right from varices, esophageal varices, gastric varices, Mallory Weiss tears, where the patient might retch and produce a tear. People who are retching and it will be very classical. They'll say multiple times they vomited. The last time they saw streaks of blood. That's how they present. It will be alarming, but it will settle. This is gastric ulcers, duodenal ulcers, malignancies, and there can be angiectasias, hemorrhagic gastropathy. Other rare causes are there, of which a dreaded complication of aortic graft surgery with fistula. So it's very important to ask if there is a surgical etiology. We do see once in a while patients like that too. And colonic bleeding, it can be because of angiodysplasias, which is very common in old age, and ischemic colitis, carcinoma, polyps, diverticular. But even if we see a diverticular, it's very important for us to determine if there's no other cause of bleed, because most of the time diverticular are asymptomatic, and carcinoma anywhere. And again, solitary rectal ulcer, fissure, hemorrhoids, and that. So if there's colonic bleeding, there are some ways of knowing where the bleeding is coming from. If it is coming from hemorrhoid or fissure, it'll be fresh blood, it'll be drops of blood, it will be splattered on top of the stool. If it is mixed with the stool, it's probably from the colon. If it is just coating the outer surface of the stool, it's probably from rectum. So this is how we differentiate, just by asking history regarding how the stool looked. And if it's red maroon stools, it is the small bowel. If it is black stools, as we said, it is upper GI bleeding. So let us look at small bowel bleeding. So small bowel bleeding causes are angiodysplasia, Crohn's, tumors, ulcers, and especially inflammatory bowel disease is becoming very common nowadays. Radiation enteritis, von Willebrand factors, and all weird causes. But the main causes will be any ulcer, tumor, polyp, or IBD in the small bowel. So in this patient, we have seen upper GI is normal, lower GI is normal. So it is an obscure GI bleeding or the small bowel is bleeding. In that, we divide it again into occult or overt, as I said. And first thing we do, as we did, is a second look endoscopy. Then if it is it's normal, then we're going to go for a capsule endoscopy. If it is a massive bleeding, like in this patient, we are not going to go for the capsule endoscopy. Capsule endoscopy was introduced for the first time here by Dr. VG Mohan Prasad, first time in India in 2001. So we have still been using it, finding it very useful, but not for this patient as he has a massive bleed. So we would go for an angiography, determine the place where it is positive, and if it has, we can directly go for an enteroscopy, directly go target the lesion and stop the bleeding. So if these are other ways of working it up, I'm not going into that. So this is how enteroscopy has evolved. First, there was just a scope where we have to push and go. And then came the capsule endoscopy where everything, there's a camera, battery, a transmitting device, everything inside one tiny capsule. Then came the device-assisted enteroscopy where devices were helping us to go through the 6 meters of the small intestine. The latest in this device-assisted is the novel motorized spiral enteroscope, which is introduced now. So look at this size. This is the push enteroscope, the older scope. You can see the size is so huge, so long, 250 centimeters, whereas this spiral enteroscope is only 168 centimeters. It is a really useful tool. Now, this is what we used here to go in to see the distal jejunum. Now we're going in with the spiral enteroscope. This is the esophagus. It is very similar to an endoscope, except it has a spiral fin and it has a motor which drives the fin, which will help to pleat the small bowel. And this pleating action will help to move forward. This is a small bowel. We are entering into the jejunum now. And you can see how smoothly it's going. There's a force gauge which shows how much force is there on the spiral segment. And there is a forward pedal and a backward pedal, which will help us to rotate forward and backward as we want. Now you can see, I will just show you. This is where the stricture was there. There was a huge ulcer with a large blood clot here. And before we remove any blood clot, we always inject diluted epinephrine. And then we remove the blood clot, because when we remove the clot, there will be a huge burst of spurting of bleeding. So here, luckily, there was nothing, but we could see a large vessel, a visible vessel. The ulcer eroded and the vessel was exposed. So we're going in and clipping the vessel with 2 clips. You can see the large clips holding this vessel over here. So that helped to arrest the bleed in this patient. He immediately stabilized and he improved. Slowly his HP came to 8, and then he had no further drop of hemoglobin, and we diagnosed him as Crohn's disease, and he's on follow-up. Thank you very much. I hope you enjoyed today's case.